what I want to do today is actually capture the topics that I found that were incorrectly coded by the majority of you all. When we're coding for cerebrovascular accidents, we want to think about it when we're looking at the patient's chart. We want to be able to identify if it's an acute stroke or if it's a previous stroke. Your physicians a lot of times document history of or previous. They don't document the words in our code book. So we have to learn how to read that chart and interpret what we need for coding purposes. So we're going to look at each one in this category. And the first one is acute stroke, also referred to as cerebral infarction and cerebrovascular accident. When it is acute, it's coded from the I-63 category. Now, in your coding guidelines, we're told to use an additional code if known to indicate the National Institute Stroke Scale. That's from an R29.7 category. And yes, that is a symptom category. But when your coding instructions tell you to code from a symptom, then that bypasses the guideline that we do not code symptoms. Your guideline, these guidelines, conventions take precedence, okay? And I wanted to show you, I actually pulled it up on my other screen. So I wanted to show you what the R29 category looks like. They're going to give you, it's a scale or a score, and it's going to range from these categories. And honestly, you won't see this often because you're going to be in outpatient coding. But if you do, if you see it in the emergency department, if you're coding ER records, then you want to make sure that you assign the appropriate code. And you find those instructional notes at your I-63 category. So there again, you've got to remember to scroll down and find a code for those inclusions, exclusions, use additional codes, because those notes is where you're going to find that R29. And there again, it's a symptom. But those inclusion notes take precedence over the fact that we are told in the overall guidelines not to code symptoms when there is a definitive diagnosis. So you want to pay attention. I gave an example here. Patient is diagnosed with cerebral infarction due to embolism of the right anterior cerebral artery. That's going to code to I-63.421. What you can do when you get when you get the recording, is you can actually sit down and work through this with Find a Code and kind of make sure that you get it. And if there's any questions, then you know to send them to me. The next condition that we'll see in our charts is sequela of CVA. That's late effects. That's residuals due to a previous stroke. They are always coded with your I-69 category. They will never be coded with I-63. So you don't want to get these two confused. There again, in the chart, the physician's not going to say, we have a sequela of CVA. They don't talk like that. This is ICD-10 coding. And that's why we as coders have to understand what our chart is saying to us. So here's an example. The provider documents right-sided weakness due to previous cerebral infarction in a right-handed individual and that is coded as I-69.351, hemiplegia and hemiparesis following cerebral infarction affecting the right dominant side. So there again, that provider, previous cerebral infarction, he may say, usually it's history of, and that throws you off, because when you see history of, you may think to go to the category history of. But if you have a residual, meaning a late effect, hemiparesis, difficulty swallowing, difficulty talking, if there's any residual late effect from a previous stroke, you will always assign from the I-69 category. Okay, let's look at the next slide. I'm going to do a little backwards here because I want to go ahead and address this because we just talked about history of CVA. Right here, if you have a history of a TIA, transient ischemic attack, or if that chart has a history of CVA and there are no late effects, no residuals, it's a Z86.73 code. It will not come from I-69. I-69 is only assigned when there's a residual. So you really want to make note of that because you're going to see that. You're going to see it in the chart at the physician's office. You're going to see it in the ED. So I want you to understand that guideline. Let's talk about the patient comes in the ED, and a lot of these, they're just not going to be physician office. But if you're an emergency room coder, that patient comes in, he has a current cerebrovascular accident, and he also has a sequela of a previous. You're going to have a code from your I-63 and your I-69 category. Example, the provider documents cerebral infarction due to thrombosis of left carotid artery and dysphagia following a previous stroke. Cerebral, you're going to assign I-63.032 cerebral artery due to thrombosis of the left carotid artery and assign I-69.321 for the dysphagia following the previous stroke. Okay, so he's having a current and he's had a previous. So at that time, you would assign both codes, a code from each category. I made these notes because I want you to do this between now and your final exam, but I want you to do this for your job, for when you're employed, because these can be very confusing guidelines. So it's a good idea to take these and look at these guidelines in your code book, in your code finder. When you find these codes, I want you to read through the inclusions, the exclusions, the code also, all the instructional notes. And then I want you to read the common language description. I want you to understand these diagnoses. They are very common. So in your official coding guidelines, chapter 9, this is A, B, C, D, and E. All this is captured in these. So just make a note, look through these, practice and find a code, coding these and becoming familiar. This one right here, this coronary artery disease with angina, you got a combo code. So you want to really pay attention. All right. The other thing, external cause coding. Um, you all did really well because we haven't went over a lot of that. So I was pleased with the results on that, but I did want to cover it today. Because there again, depending on where your job lands, um, you may have to do external cause coding if you're in that ED or if you're in a trauma center or burn unit for outpatient coding. You've got to know how to code external cause coding. Um, so I've made some notes and just a couple of slides to go over it to help you better understand it. And these slides will be available to you, so you can always reference them. But the things that I want you to know is external cause codes, they're never sequenced first. They're always additional codes. They're always secondary diagnoses. They can never be coded first. These codes, the purpose of them, they capture how the injury or the health condition, they capture the cause, they capture the intent. Was it unintentional? Was it accidental? Was it intentional, such as suicide or assault? There's different categories that falls into. They capture the place where the event occurred and the activity of the patient at the time of the event and the person's status, such as if he's a civilian or a military. Okay. One thing I want you to know is there is no national requirement for providing these codes. Your employer will instruct you as to whether or not you are to assign external cause coding. But I can almost guarantee you that if you're in the emergency department or any of these centers for trauma, you will have to assign external cause coding. So I want you to be familiar with it. So this is some little bullet points I made when you are doing external cause coding to think about. And we just covered it, but if you write it down and keep it in your notes, this will help you. All right, so first is the cause. Second is the intent. Next is the place, the activity, what was the patient doing, his status. You want to assign as many external cause codes as are available in the documentation. Not everything's going to be available. So if it's not available, you do not code it. Okay. I think I have, this is the only example I have, but we can certainly look at this at a later time, external cause coding, and I can send over any information once you look into it, into the guidelines, and see what questions you have. But this is just an example I found last night. This patient was bitten by a dog while attempting to rescue it from an abandoned barn while performing his job at an animal control center. So he was working, he was bitten by the dog, and he was attempting to rescue it in the location's abandoned barn. So we're going to code that W54.0xxa. External cause is how you're going to locate this. So this is what I've done. I've written out exactly where to go and find a code to find this code. But your main term is bite, bitten by a dog. Okay. Your next is your place of occurrence is a barn. So that's Y92.71. And you're going to go, and your main term is place of occurrence. The next is Y93.K9. Your main term is activity involving a victim at the time of event, animal care. That's his job, is to take care of animals. And then we know that he was on the job, he was working, he's a civilian based on the information that we have. So you're going to go to external cause status, civilian activity done for income or pay. So we can report the occurrence, the activity, the status, in addition to the cause for the bite. It's a lot there's a lot involved in external cause coding, but it's all documented. It's just mainly getting those bullet points in your mind. What do I need to code? This is not difficult coding. This is just making sure you understand the specifics. Okay. All right. This next one is modifiers. So we're going to talk about 51 and 59. These are probably two of the most confusing modifiers in CPT. And I want to try to help you understand when to assign each one and when not to assign each one. So we have a few slides on this. And I have some examples. So let's get started on modifiers. That should be modifier 51. So what we want to talk about here is what it indicates, what it tells us, when to assign it. So it indicates that multiple procedures were performed at the same session. So you can actually, in your notes, take these bullet points and write them down. Different procedures performed at the same session. And we're going to talk about this. I'm not just going to put it out there. We're going to do some examples and all. But I want to go ahead and get the definition in your mind. A single procedure performed multiple times at different sites. That single procedure, meaning the same procedure. A single procedure performed multiple times at the same site. Modifier 51 is only assigned when there's two or more procedures performed. And it is never assigned when a procedure is performed along with an E&M code. It's not assigned to add-on codes. So in your find a code, when you see that a code is indicated as an add-on code, modifier 51 is not to be appended to that. It also does not apply for services that require modifier 50. Those are your bilateral procedures. Okay, so that's our first overview. Now I'm going to switch over to modifier 59. This is a distinct procedural service, and what that tells us is that a procedure is separate and distinct from another procedure on the same date of service. This modifier is applied to a procedure code that is not ordinarily paid separately from the first procedure. Indications here are your bullet points for 59. Different session or encounter on the same date of service. Different procedure, distinctly different from the first procedure. A different anatomical site. A separate incision or excision, injury or body part. And modifier 59 is not appended when there is an E&M service. So if you have a 99214 and then you have a 11004 for integumentary procedure, you won't put a 59 or a 51 on that CPT procedure. Both of these modifiers apply to additional procedures performed on the same date of service as the primary. Modifier 51 differs in that it applies to procedures that may be more commonly expected. And there again, you're getting a lot of information, so just bear with me. I want you to take this PowerPoint and really study it when you receive it and go through the examples. And I will be sending more examples for you all to work on for modifiers. So here's the takeaway, what we just discussed. Here's all your bullet points. Modifier 51, additional procedure, same session. Same procedure multiple times or different sites. Modifier 59, that's a distinct procedure, a different encounter. That's like I come in the morning, I have a procedure done, I come back that afternoon, it has to be same day. And we'll talk about that again in just a minute. I have an example for that. Distinct procedure, different provider. Distinct procedure, different site. Okay, and do not use if another modifier is applicable, but you know that. Let's talk about examples. Modifier 51. This patient has an excision malignant lesion on the trunk. The measurement is 0.5 centimeters or less. It is performed at the same session with intermediate repair of wounds of the trunk. So the excision and the repair are done at the same session. You're going to use your 12032 CPT code for your excision, for the repair first. I think I'm saying that backwards. Your 12032 is your primary because it's higher RVUs. Now in the system, remember, and I want to throw this in here because when you're taking your final exam, the RVUs, you want to list the higher RVU first, unless it's an add-on code. And that should not accept that anyway. But the bottom line is your higher RVU is listed first. So you want to make a note of that. So you've got your 12032 and your 11600 with a 51 modifier because they're different procedures performed at the same session. And the RVUs are higher for the excision. Patient with bilateral simple mastectomies. You're going to code your 19303 twice with the second listing modifier 50. So you're not going to append modifier 50 to 19303. I'm sorry, modifier 51. I'm reading wrong. You will not append modifier 51 because you're using modifier 50. So when you have modifier 50, that means bilateral, right? You don't append modifier 51. It's not needed. The 50 is indicating that it's a different site. Okay, modifier 59. The surgeon documents a chondroplasty performed in the medial and patellofemoral compartments and a meniscal repair in the medial compartment. All right, so you're going to append modifier 59 to your chondroplasty because we can see here that it's a different site. And there's no bilateral issue here. This is a chondroplasty performed in the medial and patella compartments. And your meniscal repair is in the medial. So you have two procedures performed. And at a different site. A physician performs an X-ray of the chest. Subsequently, the same day, those same images are taken again. Modifier 59 is appended to the second visit to indicate that it's a distinct procedure, different encounter, same day. Had it been a different day, you would have used modifier 76, which we did not discuss today. You three guys are doing good. You're doing really good. And the thing, what I'm finding is things that as coders, when we're first starting out, they're confusing to all of us. And I want to get past that with you all so that when you start out in your career, that you've got a good foundation. That's important to me for you three, for all of you in the course, because I want you to understand, the first part, the CBA, remember the guidelines there, go back over those guidelines, your external cause codes, take a look at that, make sure you understand what to code in these two modifiers. We're not going to really go into other modifiers, maybe modifier 25. I've seen all three of you use that appropriately. I haven't seen really much of an issue with modifier 25.